very renowned intervention cardiologist and also peripheral interventionist, Dr. John C. George.
Thank you so much. It's an honor to be here again, and it's always wonderful to come back to Dhaka. It's been a while since COVID to be back here. So thank you for having me. Thank you to the panel and the organizers. So as mentioned, the topic today is going to be OCT guided left main PCI. We heard about IVUS guidance already. And so here are my disclosures. I'll quickly just get started as the topic is large and we don't have a lot of time. So we heard about IVUS imaging, intravascular ultrasound imaging for PCI of the left main specifically. I'm going to focus on OCT, which is optical coherence tomography. And we know that the resolution from OCT imaging is dramatically better with some of the images that you see at the bottom of this screen compared to IVUS. But what is OCT? OCT is an imaging modality that uses light instead of sound, like IVUS. And I'll quickly go through some introductory slides. So if you just look at the resolution on the screen, comparing CT angiography to plain angiography on fluoroscopy, to intravascular ultrasound, to OCT, you see the significant improvement in resolution and the detail that you can see with imaging. How does it work? It utilizes light. It rotates at the tip of the catheter, and you get a 360-degree view of the vessel. You have a 74-millimeter pullback that is done in 3 seconds, so you get a long length of the vessel imaged while you're doing this. And there's a variety of reasons to do this. Yeah, you heard Professor Afzalur go over IVUS and the reasons for using IVUS. And the reasons are similar. It's for intravascular imaging to get detailed anatomical information of the lesion. We have a lot of data, again, for intravascular imaging, as was just discussed right now. And so I won't belabor the point, but we also have data on OCT-guided PCI. And we know that this improves outcomes. It improves post-procedure FFR measurements. It improves TLR. And so what are we looking at? And I'll quickly go through 7 steps that we need to go through of different things to analyze with OCT. One is morphology, looking at the lesion itself, whether it's fibrous, whether it's fibrofatty, whether it's calcific, and whether there's some necrotic core, as a subacute MI patient would have. This allows you to decide what kind of treatment you're going to utilize in that patient. Second step is to look at length. Do we need to, how long of a lesion do we need to treat? And a lot of times, angiography is not specific. It doesn't tell you exactly how long the disease segment is. So if you have a distal reference and a proximal reference on the longitudinal image on OCT, you're able to exactly measure the length of lesion that needs to be treated. Step 3 is the diameter of the vessel. And when you're doing OCT, you always want to adjust the range of the vessel for the left main to definitely see the entirety of the left main, because the value of the imaging is only if you can see the entire vessel. And then once you're able to see it, you can size the vessel. It actually comes up with automatic measurements of the diameter of the vessel, which can be adjusted and adjusted to treat the distal vessel to the proximal vessel once you get the reference. Step 4 is precision in placement. And so the beauty of OCT is if it's integrated into the fluoroscopy system, you can co-register with the angiography. So this is an LAD lesion which actually shows you the angiography co-registered with the OCT, such that when you point to an area on the OCT image, you know exactly where it correlates on the angiographic image. And that allows you the kind of precision that you won't be able to get with other sorts of imaging. The next part that's attractive is the 3D guidance. You get three-dimensional imaging to be able to see bifurcations and side branches. So when we're talking about left main PCI, it gives you a beautiful image of the distal left main bifurcation into the LAD and the circ, if you get a good study, and a 3D rendition, including the stent architecture when you need it. It allows you to assess the side branch when you're treating those side branches, even with the 3D views, as you see here. It shows you how wide the stent struts are into the side branch, and you can actually determine if you need additional post-dilation based on just angiography or intravascular imaging. Next step is to detect edge detection. So now we're going to post-PCI after you do the intervention, looking at edge dissection. So if you look at this longitudinal run, it shows you a very clear image of that edge dissection and allows you to decide whether you need to treat this further or not. If you compare that to IVUS imaging, you'll see that the resolution, again, is so much better with OCT than it is with IVUS, so you're able to see a lot more with those dissections. And then apposition precision, being able to tell whether the stent struts are adequately opposed to the vessel wall. So if you look at this image on the right, you'll see those red dots are the stent struts that are not opposed to the vessel wall. So it actually gives you additional information when there's malapposition and the stent's not fully expanded opposed to the vessel wall. In bifurcations, it gives you good measurements where you might need a larger stent diameter, especially when you're going from the bifurcated vessel from the LAD or from the circ back into the left main. There's always a step up in size. And so for using PCI stent techniques such as POT, proximal optimization of the stent, you know that you need very specific size reference vessels to be able to treat adequately. And so OCT allows you to determine exactly the size, both in the bifurcated daughter or vessel versus the parent vessel. And when you're talking about this, I don't want to digress, but you also have to know what kind of stents are appropriate for those sizes. So once you get to the very large sizes, you have to pick a stent that's appropriate based on the dilation or the ability to post-dilate to the larger sizes. And then expansion precision is step 7, finding out exactly if you've adequately dilated. Dr. Afzalur went over the IVUS guidance for the ostial circ being greater than 4 millimeters squared. And so there's defined criteria on OCT as well of trying to know when your stent is adequately dilated. There's the music criteria, the IVUS XPL criteria that you heard about, and the optimized PCI criteria. They're all different criteria, but utilizing one of these would allow you to define whether your stent's adequately expanded. And then getting the minimal luminal area in those segments will then tell you whether you have adequate expansion in those segments with OCT. So I'm reaching the end of time here, but I want to quickly go over some guiding protocols that have been published. This is the October protocol for OCT guidance. This was published in the American Heart Journal in 2018. It gives you a step-by-step visualization of how to optimize stents with OCT. And then coming back to an actual trial that was done to specifically assess OCT imaging in left mains. This was the LEMON study, left main OCT-guided interventions, looked specifically at that, at standardizing protocols. And this actually utilized 4 runs of OCT to optimize the stent. And I don't want to take too much time, but there was an OCT run at baseline, an OCT run after stent implantation, an OCT run after post-dilatation, and then a final OCT run after at the completion of any adjunctive therapy. And this showed that the MACE rates were very, survival-free from MACE was extremely high at 98.6% utilizing this technique, and this is in the left main. And if you compare it to, even changes that you had to make during the run between run 2 and 3, there's significant improvement in utilizing additional runs to optimize your imaging. So with that, I'll conclude. OCT imaging is a valuable option for intracoronary imaging for left main PCI. It is advantageous for resolution, for plaque morphology, lesion assessment, and stent characteristics, as was discussed. It is feasible, it's efficient and safe, especially with standardized protocols. And the impact in left main PCI is still to be evaluated in larger randomized trials. And with that, I will stop, and I'm happy to entertain any questions. Thank you for your attention.